In Chapter 19, we will be covering the elbow, forearm, wrist, and hand. As far as anatomy goes, the elbow bones and ligaments are on this slide. Our upper arm bone is called our humerus. So this is our humerus. And on the humerus, we have the, the medial and lateral epicondyles. So those are places where we have a lot of muscle attachment. Then in the forearm, we have the radius, which is on the thumb side. So this is on the lateral side of the arm, up at the elbow, and the ulna, which is on the pinky side, which is on the medial side of the arm. The interesting thing about these bones is that at the elbow, the ulna is bigger than the radius, and then at the wrist, the radius is bigger than the ulna. So when we talk about the olecranon process, or the point to end your elbow, that is actually part of your ulna. So again, that ulna is on the forearm, in the forearm on the pinky side. Our main ligaments in the elbow, there are more than this, but the main ones are the UCL, which is the ulnar collateral ligament. So that runs from the medial epicondyle down to the ulna. And then the RCL, or the radial collateral ligament, which is on the lateral side and runs from the lateral epicondyle down to the head of the radius. The UCL is much more commonly damaged than the RCL. As far as the wrist and hand, we have phalanges in the hand, just like we have phalanges in the feet. We have 15 of those. So the thumb only gets 2. It has a distal phalange, or distal phalanx, and a proximal phalanx. And then all the smaller fingers have 3. So they have a distal, middle, and proximal phalange, or phalanx. The thumb has a special name, just like the great toe. The thumb's special name is pollex. So digit 1, or the thumb, is called the pollex. Our fingers are called digits, so digit 1 through 5 is how you'll see them called by doctors oftentimes. Our metacarpals are the long bones in the middle of the hand, so these are our metacarpals. And our carpals are our wrist bones. So depending on how your personal anatomy is, the wrist bones may look like they're just in the wrist. My carpals happen to be very long, so they actually come up pretty high. I'll show you guys in class when we're taping for wrist. But those carpals, again, are mostly the wrist bones, or those are the wrist bones, but they should look like they're primarily the wrist. We have many carpals, so we have the trapezoid, the trapezium, the capitate, the scaphoid, the hamate, the pisiform, the triquetrium, and the lunate. I'm sorry, the triquetral and the lunate. So as far as the carpals go, though, the main ones that you're going to need to know for class as far as being commonly injured would be the scaphoid. This is on the thumb side, and it takes up actually about a half of the wrist on the thumb side. The hamate, which is on the pinky side of the wrist, so it's right through here. The main part that we're concerned with is the hook of the hamate, so this little projection right there. And then the lunate, which is right pretty much in the middle of the wrist. So the lunate is right here. So the scaphoid, the lunate, and the hamate are the most commonly injured. As far as the muscles and tendons of the elbow, we have on the anterior side of the arm, on the anterior side of the humerus, you have the bicep, and the bicep tendon does cross the elbow joint and attach down on the ulna. And we also have, so that's one of our flexors. Another elbow flexor would be the brachialis, which is deeper inside. And then we also have the brachioradialis that runs from the humerus all the way down to attach to the carpals. And you can see this one the most if you kind of give yourself a thumbs up and then radially deviate towards your elbow. You'll be able to see that brachioradialis a little bit better. But those are all of our elbow flexors. We have elbow extensor in the back, which is basically the tricep. So tricep attaches to the humerus and comes down to attach to the ulna. Then deeper inside to the other muscles, we have the supinators. So the supinator up here at the elbow helps to turn your palm up. The pronator teres right here at the elbow will help to turn your palm down. You do have another pronator at the wrist as well that helps to turn the forearm. As far as your wrist and finger flexors, these all originate on the medial side of the arm at the lateral epicondyle. These are and they follow a path of following the medial anterior side of the forearm when we're in anatomical position. So from an anterior view, these muscles are going to run this way down the arm here. So the wrist flexors are going to stop, at the carpals at the wrist, and the finger flexors are going to continue down to the fingers. So those wrist and finger flexors are going to come from the medial side of the forearm and from the lateral or medial epicondyle. On the lateral side of the forearm, we're going to have our wrist and finger extensors. So those are going to come from the the lateral epicondyle down the lateral posterior side of the arm, down to the wrist, and down to the fingers as we go here. So all of those extensors, the wrist and finger extensors, are coming from the lateral epicondyle. As far as injury prevention, the protective gear recommended to reduce severity of injury will depend on sport. So say for instance for soccer you don't wear any forearm protection because the forearms are not commonly injured or the wrists are not commonly injured in soccer. But for lacrosse it's required for high school and college lacrosse to wear elbow and forearm pads, say for instance. For little kids learning how to ride a bike or a scooter or something like that, it's a really good idea. It can really help reduce the risk of injury for them. Big thing, try to avoid fooshing. Falling on an outstretched hand is a really good way to hurt yourself, all the way from your hand up to your shoulder. So you want to avoid that. Tucking and rolling is better. As far as chronic injury reduction, we'd like to try to limit repetitions. This would be primarily for baseball and tennis. That's when we see issues the most. Sometimes people who play softball will have some problems as well, and with their elbow or their wrist. But we do see this more commonly in baseball. We want to have people be using proper throwing mechanics. So a baseball pitcher, say for instance, who throws more overhand is less likely to have elbow pain than a pitcher who throws more sidearm or subterranean. The more torque that somebody's putting on their elbow, then they're more likely to cause pain or discomfort or an injury. We want to use equipment that's appropriate for skill level and size. So an example of this would be using a proper racket grip size in tennis. If somebody's grip size is too big when they're playing tennis, it can predispose them to getting lateral epicondylitis or tennis elbow. Another thing would be making sure that a racket wasn't too long for the person as far as their body size. Same thing for something like lacrosse. Littler kids are going to need littler, shorter sticks. And we also want to make sure that people are maintaining appropriate levels of strength, flexibility, and endurance for an activity. So for people who get overuse elbow and wrist injuries with manual labor type of jobs, some bigger companies actually have what they call work hardening programs. We had one at UCSD, and they did a lot of prehab basically, or workplace fitness for individuals who, say for instance, were on the cleaning crews. because they were using this steam cleaning equipment that put a lot of stress on their elbows and forearms. So it's really interesting that they were working on that to try to reduce their risk of injury and try to get them stronger. And they were also incorporating flexibility exercises for those people as well. So as far as assessment and history, remember that the information provided here is for informational purposes only. We're going to want to know the person's past history of injury with the elbow, forearm, hand, or wrist. What was their mechanism of injury? Did they foosh, or did it just come on? They don't know how it started. When and where does it hurt? So what activities cause pain, and where is their pain? What motions increase or decrease pain? What is their type, quality, and duration of pain? So remember sharp, dull, achy, throbby, and how much would be helpful. Do they have any sounds or sensations like clicking, popping, numbness, or tingling? Numbness and tingling is usually an indication of nerve injury. Do they have any swelling or previous treatments? As far as swelling of the elbow, it's actually pretty difficult to see. So there's specific positions where we try to put them in to make it easier to see that. As far as observation and palpation goes, with observation, we want to look for deformities and swelling. If somebody is able to hold their elbow at a 90-degree angle, we'd like to have them do that and look at them from behind so we can observe the triangle that's formed by their medial and lateral epicondyles and their olecranon process of their elbow, because that's we tend to see the most swelling somewhere in that triangle. So if we actually do see swelling in the elbow, most of the time it's most readily apparent by looking at them from behind, but occasionally we can see it from the front. We're going to want to look at the carrying angle of their elbow. So do they go into valgus or varus? So just like with the knees, valgus is, knock-kneed, so elbows towards the body, or varus would be elbows away from the body when their arms are straight at their sides. And we'd also want to look for hyperextension. So this is a pretty hyperextended elbow there. That's just telling us that the joint has more laxity possibly than it should have. That hyperextension is more common in women than in men, but men can have it too. We want to check their range of motion. So check, are they able to bend their elbow all the way? Are they able to straighten it all the way? Are they able to supinate and pronate all the way? If it's a wrist injury, can they flex and extend, do ulnar deviation, radial deviation? Check the finger range of motion. We just look for anything that's painful or abnormal. We want to see if they'll use their hand and arm normally. So if it's their dominant hand, are they able to write with that hand right now, or is that difficult? Do they find themselves reaching to open doors with their other hand, or can they use that one normally? Another thing we'll look for is a thumb to finger touch. So a lot of times if somebody is pretty swollen with their thumb, I'll have them start off with their index finger actually. So I'll just have them start off by trying to touch each finger with their thumb. If they're able to get all the way across to their pinky, then they have a relatively normal range of motion with their thumb. For palpation, we want to be sure to check for sites of pain and deformity, starting with the bony landmarks that we talked about, like the epicondyles and the olecranon process and the heads of radius. And then we'll check the soft, and then going down into the wrist and trying to check over the area of the carpals and the metacarpals and the phalanges. And as far as soft tissue, we'll check the muscles, tendons, joint capsules, and ligaments surrounding the joint to try to see if we can figure out where they're hurting. As far as injuries to the elbow, the first one we're going to talk about is an elbow sprain. And usually it's the UCL that's sprained, that's most common. This can happen either from elbow hyperextension, so like if somebody fooshes and their elbow hyperextends, or goes into a valgus force. But also that valgus force can be created just by throwing. So pitchers who are throwing at a high velocity are creating a really big valgus force here at the elbow when they have that little tiny weight at the end of their hand that they're trying to accelerate really quickly that way. So sometimes with pitchers, this actually isn't even from one pitch, it can just be over time. Our signs here would be pain along the medial aspect of the elbow, point tenderness over the UCL, so this is where the UCL is, and inability to grasp objects. So they're going to have some decreased grip strength. So that's a pretty telltale sign of UCL sprain. Treatment here would be conservative treatment would be putting the elbow in a sling for at least 24 hours and doing price, and then gradually working on pain-free elbow range of motion, and working the way back up into strength, usually starting with grip strength. That's not usually painful, it's just weak. So we'll start with grip strength, and then we can start to do some elbow flexion and extension, and then working our way into supination and pronation and ulnar and radial deviation. As far as throwing athletes especially, they're going to want to modify their activities. So we'll want to have a gradual progression of increasing throws until the range of motion and strength return. People are usually opt for this for a little while. If the elbow is unstable and they're not able to do the graded reconditioning and return to play, then surgery may be needed. This is called the Tommy John's procedure, named after the first athlete to have done, I guess. And the main thing with this that I think is a good takeaway is that this is a pretty big rehab. It's a long surgery to recover from. It's actually longer even than an ACL surgery. So if this is something that we can avoid, we should. But and the other thing is, a lot of times pitchers never get their full velocity back after they've had this injury or this surgery. It could easily be a career-ending injury for a very high-level pitcher. This is another one of our paired injury slides. So our injuries here are the epicondylitis. So epicondylitis just refers to an irritation of the tendons at the medial or lateral epicondyle. So if somebody has more medial epicondylitis or irritation of the wrist flexors, we tend to call that golfer's elbow. And if somebody has lateral epicondylitis or irritation of the wrist and finger flex or extensors, we tend to call that tennis elbow. But people can get lateral epicondylitis from golfing, or people can get tennis elbow from, people can get medial epicondylitis from playing tennis, I guess technically, but these are just more common with those sports. Our mechanism here for medial epicondylitis would be repeated wrist flexion with a valgus force, like with pitching. So this can be confused a little bit with a UCL injury, especially if that UCL injury was chronic. But we often see this with golf as well. And those wrist and finger flexors tendons become irritated right at the epicondyle. For tennis elbow, repeated wrist extension, irritation at the wrist and finger extensor tendon attachment. So another type of activity this can happen with is people who are just doing any kind of repetitive extension. So grocery checkers, you'll see sometimes will get this as well. Signs of injury for both of these would be aching pain after activity, weakness in the wrist and hand, especially with the respective tendons, decreased range of motion, especially with putting those tendons on stretch. So for medial epicondylitis, they may have restriction with wrist extension. For lateral epicondylitis, they may have restrictions with wrist flexion stretch. When the individual with medial epicondylitis does active wrist flexion, so like a wrist curl, they're going to have pain at the medial side of the elbow. When somebody with lateral epicondylitis has pain, they'll have pain with wrist extension, or like coming up with a weight especially. So they'll have pain with stretch and muscle activation with these muscles. Our treatments here will be price and NSAIDs for both, stretching, massage, and strengthening. Tape or neoprene sleeve, possibly. There is a special kind of strap that people will wear sometimes for lateral epicondylitis that they can find. You could find that pretty much anywhere, but it can help make the person more comfortable, and it just kind of goes on the forearm a little bit below where they're having pain. We also want to make sure that the individual is using proper mechanics and equipment that is properly sized for them. So for lateral epicondylitis, really looking at that tennis racket to make sure that the grip is the right size for them would be important. As far as an elbow dislocation, this injury tends to be a little bit more serious because the elbow joint itself, where the olecranon or where the ulna is attaching to the humerus, is a pretty strong joint, and it's hard to dislocate that. So usually in sports, that's caused by fooshing with the elbow extended or a severe twist while flexed. Another type of dislocation we can get at the elbow is the radial head dislocating, and that's a little bit more common. We call it nursemaid's elbow, but it primarily happens with little kids, and most often it happens when you're holding the child's hand and you pull on them in some way, so either to get them to come along with you, or if they're being swung around by their hands, or in my son's case, we dislocated his elbow twice, or his radial head twice, when he was about not quite 2, because we were holding onto his hand tightly, and he threw a tantrum because he didn't want to come with us, and he picked up his feet and kind of twisted his body in the air, and his radial head dislocated. Our signs of injury here would be swelling, severe pain, and disability. Sometimes with the ulna displacing from the humerus, you can have fractures and things like that, and we can have damage to the blood vessels and nerves, so a lot of times this is very painful. As far as the olecranon process of the elbow goes, it can be displaced forward, like in this picture, so this has slipped forward. It can be displaced backwards or laterally, so side to side somehow, but more out to the lateral side, more likely. And again, this can cause a lot of damage to the nerves and blood vessels, so it tends to be a more serious dislocation than, say, for instance, the shoulder. And we can get tearing of the stabilizing ligaments. Care here would be to immobilize the elbow, so in a sling, if they're in a position that they can stay in a sling, or they can just make sure they're holding their arm and they don't move it. And we'll send them to the emergency room for reduction by a physician. Following reduction, the elbow should remain splinted in flexion for 3 weeks, and we can do a normal price and whatnot as well. For a nursemaid's elbow, it's slightly easier to get back in. You can either and doesn't cause as many complications. And usually with the little kids, they say it doesn't cause any lasting problems. Another type of injury we can get at the ulna or at the elbow is the ulnar nerve injury. So the ulnar nerve runs through this groove between the olecranon process, or the point of the elbow, and the lateral epicondyle, and sometimes it can get irritated. We also affectionately refer to the ulnar nerve as the funny bone. So when somebody has that type of feeling where they've hit their funny bone, they could actually be causing ulnar nerve damage. Oftentimes this injury is more chronic though, so it can happen when somebody has a very severe cubitus valgus, so where they're having the elbows touching their sides and their hands coming out away from their body. That can cause a deep friction problem that causes irritation and swelling in the nerve. We can have ulnar nerve dislocation or subluxations. So if the covering over the nerve that holds it down here isn't tight enough, the nerve can move around more than it should and cause irritation. And we can also get a traction injury from the valgus force, so like pitching, irregularities within the tunnel, so maybe there's like a little bone spur or something rubbing on it, or progressive compression of the ligament on the nerve, or even progressive compression in any way. My supervisor at Michigan gave himself ulnar nerve problems from leaning on the armrest in his wife's car. When he would drive that, it would cause him a lot of issues. Signs here would be generally paresthesia or numbness in the 4th and 5th fingers, so the pinky finger and the ring finger, very specifically there. So if somebody's having numbness in different fingers, that would be a different injury. Treatment here would be conservative management as far as avoiding aggravating activities, so we try to have the person maybe not throwing as much if that's causing a problem. We'll put them in a night brace, because a lot of times when people are having ulnar nerve injuries or ulnar neuritis, they'll have they'll have more numbness or tingling or pain if they wake up with their arm or elbow completely flexed or completely extended. So we usually put them in a middle position. We'll also use modalities and ice to try to calm it down. If the nerve is not able to be calmed down through physical therapy and using modalities, the individual may need surgery if either it's not responding or the stress on the nerve can't be avoided. The person that I've seen that's had the worst ulnar nerve injury was actually an athlete who had a Tommy John surgery on his UCL, and then he had a bunch of scar tissue that ended up putting a lot of compression on the nerve. And I don't know how I missed it. I wasn't really looking at his hand very much, but he came in one day and he said, you know, I feel like I'm getting stronger, but my hand just still looks like a Skeletor hand. And I looked down at his hand, and there was very little muscle between the bones in his hand, and it looked remarkably different from the other side. I immediately referred him to an orthopedist, and he ended up having surgery on his nerve, actually, to remove a bunch of scar tissue, and then they also moved his nerve over. So what the doctor or what the surgeon will do is they'll take the nerve out of this tunnel, and they'll actually put it on the anterior side of the elbow or the forearm, and then that usually takes care of the problem. And thankfully, that individual's hand musculature went back to normal after that surgery. So the picture on this slide is literally my least favorite picture of all time, I think. Open fractures completely ick me out, but that's a radial and ulnar fracture, an open fracture there. Forearm fractures are more common in younger kids due to falls and direct blows. My son actually fractured his radius and his ulna, just a real small fracture falling off of a step stool over Memorial Day this year. So when people have forearm fractures, they can fracture the radius or ulnar or both. They're not always as severe as in this picture. Our signs would be a pop or a crack followed by moderate to severe pain, swelling, and disability. My son was actually able to use his hand, and we splinted him, and we didn't want to take him to the emergency room because the copay was so expensive, so we were trying to wait to go to urgent care, and he was able to go swimming and use his hand completely normally unless he fell on it, and then he would break down crying. So he had some pain, but then it just kept getting worse when he kept falling on it. The individual will have edema or swelling and possible crepitus. So if the ends of the bone are no longer together, so if it's more of a complete fracture, then they can have crepitus with the bones rubbing on each other. An older athlete can experience more extensive damage to the soft tissue structures. As we age, our bones become more brittle, and when we have a fracture, those sharp pieces, or the bone tends to become more sharp pieces, and instead of doing more of a bending like a younger child would have their bones do, and so that those sharp pieces can cause more damage. Treatment here would be price, splint, and refer to a physician. So we would try to make sure people go to the emergency room. My husband again is a physician assistant, so we did splint my son, which he was in a splint for 10 days anyways. The urgent care just gave him a better one. And then usually the athlete is casted for 8 weeks. As far as wrist sprains go, these usually are less serious than a fracture, say for instance. Our wrist sprains are our most common wrist injury. So basically, we could have a sprain of any of the ligaments that attach the joints together in the wrist. So technically, it would be a wrist sprain if we're talking about the distal radial ulnar joint here getting sprained, or we could have sprains between any of the carpal bones and then the nearby carpal bone. Those are really common. Or we have ligaments on the medial and lateral side of the wrist as well that can get sprained. So there are a lot of different ligaments that can be damaged in the wrist. In the photo below, where the person is having a lot of swelling, that would, just based off of where their swelling is, I think that's probably more of that distal radial ulnar joint that got sprained. But that's a really swollen wrist. We don't usually see that much swelling in a wrist. So wrist sprains can arise from any abnormal or forced movement. often from falling on a hyperextended wrist, so falling down with fushing basically, with the wrist hyperextended, a violent flexion or a twist. Signs here would be pain, swelling, and difficulty with movement. And treatment would be to refer to a physician for x-rays if we think that the symptoms are severe. A lot of times scaphoid fractures can seem like wrist sprains until we see on the x-ray that the scaphoid is fractured. We also want to do price and give the person pain relieving medications like Tylenol or ibuprofen. So price, maybe that would be just putting them in a wrist splint or putting them in a SAM splint. We want to have the athlete begin strengthening soon after injury, so starting with grip strength and finger strengthening and moving our way up into wrist flexion and extension and radial deviation and ulnar deviation and supination and pronation as the person can tolerate. We also can tape them for healing and prevention of further injury. One of my worst wrist injuries that I've had as far as wrist sprains was an athlete who completely tore one of the ligaments in his wrist, and he ended up having to have surgery. He's a rugby player, so I made him do all kinds of stuff in rehab after he was discharged from hand therapy, and we actually got him back to the point where he only taped because I basically made him for one season, and after that he never even needed to tape again, never had problems with push-ups, anything like that. I've had people with minor wrist sprains have pain with push-ups for the rest of their life. So if we're appropriately reconditioning people and we're appropriately strengthening even these minor injuries, people can have a lot better quality of life after them. As far as wrist and hand fractures, most commonly fractured bones in the wrist and hand. In the wrist, we have the scaphoid, which is on the thumb side of the wrist, the lunate, which is more in the middle of the wrist, and the hamate, which is more on the pinky side of the wrist. We also have our metacarpal, which is commonly fractured. Metacarpals are commonly fractured. The scaphoid is the most commonly fractured. The lunate is the second most commonly fractured. The lunate is also the most commonly dislocated, though. And then the hamate would be third. People often fracture their fifth metacarpal when they punch something, so we call this a boxer's fracture. So this very special gentleman down here has a boxer's fracture. I can tell by the way he's splinted. I have a feeling he's still drunk based on the look on his face. But that if you see somebody casted with the pinky finger and the ring finger in slight flexion and their wrist is casted, they're casted for a boxer's fracture. They punched something, they broke their hand. The scaphoid, if you fracture that, they'll have pain in the anatomical snuff box. So the anatomical snuff box is this little space right here. So if you give yourself a thumbs up and then look down at the back of your wrist, you'll have a little divot that's just at the base of your thumb at your wrist, and you can kind of even put your other index finger in it, and that is called the anatomical snuff box. So, way back when, before cigarettes became popular, or even smoking a pipe became popular, people used to use tobacco in the form of snuff. So they would snort it up their nose. And if you were very rich and had a lot of money, you would have a special little spoon that you used to snort your snuff up your nose. But if you didn't, you might put your snuff in your anatomical snuff box. So you might put that in that little divot and then put that up to your nose and then snort the snuff up your nose. That's why it's called the anatomical snuff box. A mechanism for fractures is commonly foosh, or a blow to the wrist or hand, or giving a blow from the hand, like punching. Our signs here would be swelling and severe pain over the bone. Possible deformity, oftentimes not, but with the boxer's fractures we can sometimes see deformity. Our treatment would be price and analgesics, so splinting if it seems warranted, and we want to refer them for x-rays prior to casting. The person is going to be splinted until their swelling goes down, and then they'll get a cast. Immobilization will last for about 6 weeks and is followed by strengthening and protective tape as needed. So if somebody had a boxer's fracture, I'd oftentimes tape their ring finger and their pinky finger together just to help protect that bone a little bit more. And you can kind of tape around the hand. For wrist tape, we can do lots of different types of wrist tape. You guys are learning the the most basic wrist tape, but there's a lot of other types of tape we can do to help protect that wrist as well. The biggest thing with the scaphoid is it is at a risk of failing to heal due to poor blood supply. So it is really important that we're accurately assessing these injuries or sending the people for x-rays if we're concerned about the scaphoid being injured. I will say that my stepmom, who's a very intense athlete, even at her age, she fractured her scaphoid playing tennis because she tripped and fell. And I actually saw her that day, and I looked at her wrist, and she actually didn't have pain in the anatomical snuff box. And so I said, go to CVS, get a wrist splint. If it's still hurting, go to the doctor. I am concerned because you're having pain on that lateral side of the wrist, but it's not hurting over the bone. And she went to the doctor probably like a week later because it was still hurting, and they did an x-ray, and it was fractured. They gave her a removable cast, which was a terrible idea because she wouldn't leave it on, and she kept doing housework when taking her cast off. And so they ended up actually she was in a hard cast for about 6 months because they finally ended up having to just cast her to keep her from moving it, and she ended up with a bone stimulator and all kinds of stuff. So she got lucky in a way because she didn't have to have surgery, but this was a very long, drawn-out process because she wasn't adequately protecting that fracture. As far as injuries to the fingers, usually with a regular finger sprain, or digits 2 through 5, our mechanism here is going to be an axial force to the tip of the finger. So basically a ball will hit the tip of the finger, or somebody will run their finger into something, and that produces the jammed effect. Our signs of injury would be moderate to severe point tenderness at the joint, and maybe some joint instability. So if we do some joint play, I usually kind of basically do the same types of joint movements I would do at the knee, because the finger is almost like a little tiny knee. And if they have joint instability in that finger, then that would be an indication that they maybe have a more moderate sprain or severe sprain of the finger. Care would be icing for the acute stage. Oftentimes it's easiest to ice the finger by filling up a cup with ice water and then just sticking that finger in there. And then extracted roll-out fracture and splint for support. For thumb sprains, these are a little different. The thumb is pretty special because it needs to work better than a lot of our other fingers, because we're using it for opposition, we're using it for gripping, eating, opening doors, like all different kinds of stuff. So the thumb is in a lot of ways more important than the other fingers. As far as our mechanism here, most often people sprain their UCL, so that would be the UCL of the thumb is here in the web space of the thumb. And that can happen by forceful abduction, or pulling out like this, or hyperextension or pulling back like this on the thumb. So actually the thumb tape job you guys learn in class is specifically for this UCL sprain. Our signs of injury are pain over the UCL or in that web space, a weak and painful pinch, so that if you ask them to pinch their thumb and their second digit together, they won't be able to keep it together as well as the other side. They could have swelling over the medial thumb or the whole thumb. And if we feel like they're unstable, if we've done some joint play and they're unstable, we'll want to refer them to an orthopedist to see if they have an avulsion fracture possibly. We may want to have them go in for an x-ray to rule out fracture if it seems like they have enough pain to warrant it. And we'll want them in a thumb splint for 3 weeks or until they're pain-free. I will say that I definitely have taped people for thumb injury and let them go back to play if it was a big game, but it depends on how weak and painful and unstable that joint is. I won't do it for every person. Next, we have finger dislocations. So this most often occurs when somebody has a blow to the tip that forces the finger backwards. So it can be backwards like this into hyperextension, or the whole phalange will just get shifted backwards, like kind of forced backwards out of the joint, and then the whole thing kind of gets shifted up and back. Those are both pictures of dislocations. They just look a little different. This results in tearing of the joint capsule and hemorrhaging. There can be rupture of the flexor extensor tendons possibly, but that's not super common. and they could get a chip fracture. So generally speaking, the reduction should be done by a doctor instead of doing it yourself. The person's going to have pain and deformity. These are pretty obvious. And usually the doctor is going to do an x-ray to rule out fractures, and then the person will be splinted for 3 weeks in 30 degrees of flexion to allow the best healing of that joint capsule. Improper splinting could lead to instability or excessive scar tissue where the person is going to now be limited in their range of motion with that finger. If the person is not able to wear a splint while they're playing, then we'll buddy tape for support upon return. If I'm really worried about somebody's finger, a lot of times if I can get away with it, I'll leave the splint on and then buddy tape the fingers together for play as well. For rugby, they weren't allowed to have any metal, so I would either use the softest splint I could find, or I would cover the metal with padding and kind of cheat a little bit. As far as injuries to our tendons, the first two we're going to talk about are injuries to the finger extensor tendons. So the first one is called mallet finger. So this is a picture of mallet finger. So basically that distal phalange is held at 30 degrees from the rest of the finger, and that person cannot extend it, that it's just stuck in that position. This happens when somebody gets a blow to the tip of the finger, and then the tendon that's supposed to attach here kind of under the base of the nail gets pulled off. So you have a little avulsion where that tendon gets pulled off from the bone and is no longer attached. Our signs here would be tenderness over that attachment site, and then x-ray will show an avulsed bone, so the bone will have gotten pulled off a little piece of bone will have gotten pulled off of the main part of the bone on the dorsal proximal distal phalanx, so right under the nail there. And the person's going to be unable to extend their distal end of their finger. It'll just be stuck in that position. Treatment here would be price and splinting. We want to splint that little joint in hyperextension for 6 to 8 weeks. So we splint it kind of up, maybe not that severely, but something to that effect. And we try to get them to leave the splint on as much as they can for 6 to 8 weeks. These can heal themselves. That's a really good news as long as the person is taking care of it. The other type of extensor tendon injury we have would be occurring more at the proximal phalanx or the proximal the interphalangeal joint, so more proximal to that distal injury. This is called a boutonniere deformity, and the mechanism here is a rupture of the extensor tendon dorsal to the middle phalanx, which forces the DIP into extension and the PIP into flexion. So basically we get this type of positioning with the finger because the tendons have ruptured and split over this joint right here. I've actually never seen this in real life. It's not super common. The mallet finger is much more common as far as what I've experienced. I thought I saw this once, and it turns out the person just had a fracture. It just made it look exactly like this. Our signs of injury are severe pain, obvious deformity, and an inability to extend the DIP joint. So with both of these injuries, the person cannot move from that position. As far as other signs, they're going to have swelling and point tenderness more at this joint right here, at the proximal interphalangeal joint. Our treatment would be price, splinting that PIP or this joint for 5 to 8 weeks, and we're going to encourage the athlete to flex their distal phalanx. So the splint would actually be straight up until this point. So we stop the splint right here, and we give them access to moving the tip of the finger for that particular injury. Finger flexor tendon injuries are actually more serious than the extensor tendon injuries because they don't heal very well. Jersey finger is an example of that. This particular individual is really trying to bend this finger. It just won't do it because they've had a rupture of their deepest finger flexor tendon called the flexor digitorum profundus, and it's torn on the palm side, kind of around in this region. This is most common in the ring finger when somebody tries to tackle another person by grabbing onto their jersey, or they're trying to control them by holding onto their jersey. Then the other person tries to run away, and that ring finger tendon is just not strong enough to hold on to them, and it ruptures. With this injury, the distal interphalangeal joint cannot be flexed and the finger remains extended when they try. They're going to have pain and point tenderness over the distal phalanx on the palm side. Treatment here would be that this must be surgically repaired. It's not going to heal on its own. Rehab will require 12 weeks, and there's often poor gliding of the tendon, so the tendon often doesn't heal very well, and there's a good possibility that it's going to re-rupture. These are not real easy to fix, and they don't tend to stay fixed, unfortunately. Last but not least, in our elbow, forearm, wrist, and hand lecture is rehab. So for elbow injuries, we'll often include shoulder exercises. So maybe flexion, extension to try to get the bicep and tricep more involved. And we'll also try to avoid weight bearing for wrist injuries if they're painful. So one way we can do that is if we're having somebody do push-ups, say for instance, we can put them on dumbbells like this to keep the wrist in a more neutral position, and that's oftentimes less painful than trying to do a regular push-up. Sometimes people will do fist push-ups where they're on their knuckles. I personally find that really uncomfortable, so I don't usually recommend that. I usually try to do dumbbells if I can. We want to focus on grip and extension activities for elbow, wrist, and hand. One tool that I really love for this is called a Handmaster Plus. So what it is, it's a little stress ball that you can squeeze for the finger flexors, and then attached through that, so it actually goes through the middle of the ball, are these little rubber band things that you can loop over your fingers to strengthen the finger extensors. And this picture actually shows all the different resistance levels. So the blue is the least resistance, red is medium, and orange is hard. But I've used these for years and I really like them. We can also use dumbbells for resistance for wrist flexion and extension, ulnar deviation and radial deviation, and supination and pronation as well. And that is the end of our elbow, forearm, wrist, and hand lecture.